Good afternoon, everyone. Today I'm going to discuss about the golden hour in the management of eclampsia and severe preeclampsia. I have 8 minutes to tell you what you should do in the first 60 minutes. So this was preeclampsia, severe preeclampsia and eclampsia. Now you know that eclampsia is the most severe manifestation of preeclampsia, and it is the onset of convulsions, generalized tonic-clonic type of convulsions, and this can occur at any time. It can be the antepartum period, during labor, and in the postpartum. It's most commonly within the 48 hours of delivery and carries a very significant risk to both mother and to the baby. Now, what should be our emergency eclampsia management? Well, there is airway patient safety, there is BP stabilization, there is institution of magnesium sulfate, continuous monitoring both of the mother and the baby, presence of the antidote in your labor rooms, and a firm resolve that delivery should happen within the next 12 hours after the first fit. So that is very important. So we have 60 minutes, and the golden hour actions should be: first, we confirm that our patient's blood pressure is very high, we secure an IV line, we send the laboratory investigations, we start the blood pressure medicines, and Maxelf, the miracle drug. Coming to blood pressure control, to prevent a stroke, control severely high blood pressure more than 160 by 110 immediately with intravenous or oral agents to prevent stroke. But remember, you must avoid aggressive lowering so as to protect the baby. The uteroplacental flow should not get affected. All of us must know the first line antihypertensive agents. You can decide what is your protocol in your hospital. We have labetalol and nifedipine are the two we use. Some of you are also using hydralazine. Labetalol is very safe and it should be used immediately. IV bolus, the action is very quick in 1 or 2 minutes. 10 to 20 milligram to be repeated 20 to 80 milligram intravenous every 10 to 30 minutes. And the only contraindication for this is if your patient has bronchial asthma, has heart block, or has decompensated cardiac disease, in which case go to the second line, that is nifedipine, or if it is refractory to labetalol. Labetalol IV we know is safe. It can be used up to a total of 300 milligram. Hydralazine is being used in some centers, but we prefer to use labetalol and nifedipine. Seizure prevention and control, very important. It is really seen that gynecologists do not use magnesium sulfate for the prevention of seizures in a case of severe preeclampsia, but we must use it both for prevention as well as for treatment. A little thing to remember, that do not use magnesium sulfate for the purpose of blood pressure reduction, but only for the prevention and management of seizures. Eclampsia, the immediate maternal safety measures to protect the patient are to protect the airway, to administer oxygen, to prevent physical trauma to the mother. This position is very important and must be remembered because it keeps the airway clear and it prevents choking. So, emergency care involves airway, oxygen, lateral decubitus, suction, monitoring heart rate and blood pressure, and intravenous access. Avoid maternal injury, elevate and pad bedside rails. Never keep the patient alone. Prevent recurrent seizures. Magnesium sulfate, we all know the dosage. There are two regimes, Pritchard and Zuspan. You can decide which one is the one that is there in your hospital and stick to it. Keep the chart so that all your residents and everyone knows how to give it. Control severe hypertension. This chart can also be kept in the labor room with doses of all the 3 drugs that you are using, or all the 2 drugs that you are frequently using, which is labetalol, hydralazine and nifedipine. Send the laboratory tests and do fetal monitoring. If there is a recurrent seizure, you can give a second bolus of 2 gram IV magnesium sulfate, and in a refractory seizure, you can give lorazepam 4 milligram intravenous. Once the signs are stable, think of delivery and decide how you're going to deliver the patient. Yes. So, coming to, if the patient has had an eclamptic fit at any gestational age, you stabilize the mother, give magnesium sulfate, do the blood pressure control and proceed to delivery. Immediate and emergent delivery is to be done once the patient is stable. If there is severe preeclampsia more than 34 weeks, stabilize the mother, give magnesium sulfate, do a blood pressure control, and soon after stabilization, you should deliver within 24 to 48 hours. Now, what happens if you have a severe preeclampsia who is less than 34 weeks? You can go for an expectant management in a tertiary care center by stabilizing the mother, administering Maxalv and giving corticosteroids for fetal lung maturity. And after the completion of corticosteroid course, provided the mother and fetus is stable, you may wait for 48 hours or even longer depending on how the patient, both the mother and the baby are. But a word of caution, emergent maternal and fetal indication at any gestational age, delivery is the only solution. So this is often targeted within less than 30 minutes for a cesarean section if there are emergent conditions like an abruption or fetal distress. A little word about expectant management. Blood pressure is controlled below the severe range. If lab values are stable, there are no severe or intractable symptoms, there are no signs of fetal distress or compromise. But if the mother or the baby deteriorates at any point during expectant management, delivery is required immediately. So to recapitulate the take-home messages on managing acute preeclampsia and eclampsia, the 60-minute rule for the mother. The threat is the blood pressure. Systolic blood pressure more than 160 by 110 is a stroke level emergency. Action is immediate. You have 60 minutes to start the first line agents, levetolol, nifedipine or hydralazine. Bring the blood pressure down to non-severe range. Maxalv is not an option, it is mandatory. It is mandatory in severe preeclampsia and confirmed eclampsia. It is also neuroprotective. Watch the clock, watch the reflexes. While magnesium is life-saving, power demands respect. Keep a watch on the 3 R's: reflexes, respiratory rate, and renal, that is a urine output. And delivery, the final step, the only cure. Remember the golden rule that delivery is the only definitive cure. Every other action is just buying time. We have a very narrow window if you are considering expectant management for a stable patient removed from term. You treat that 24 to 48 hours as a fragile window of opportunity. It slams shut and it mandates immediate delivery the moment the mother or the baby shows any signs of fetal distress. Thank you.